Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
I am Dr. Colin Crowe, Assistant Professor of Family and Community Medicine at Case Western Reserve University, a family medicine physician at Metro Health, and podcast lead for Cardio's Team Best Practices. With me today is Dr. Glen Solomon, Professor of Medicine and Chair of Internal Medicine at Wright State University Boonshoft School of Medicine. In his clinical practice, Dr. Solomon works as an internist and headache medicine specialist and sees patients in Dayton, Ohio. He is also a member of Cardio's Team Best Practices. In this podcast, we will talk about the role of headache disorders, particularly migraine, as a risk factor for cardiovascular disease, and how cardiovascular disease may impact the treatment of headache disorders. Welcome, Dr. Solomon.
Thank you for having me.
So, to begin, why are headache disorders important for primary care providers?
According to the Global Burden of Disease study, headache disorders are amongst the most prevalent and disabling conditions worldwide. Each day, roughly 16% of the world's population has a headache. In the United States, 18% of women and 6% of men suffer with migraine, while 3% of the population have chronic daily headaches.
Before we dive into the relationship of cardiovascular disease and headache, could you review with us the types of migraines?
Absolutely. There are 2 major types of migraine: migraine without aura and migraine with aura. Migraine without aura is a recurrent headache disorder with attacks lasting 4 to 72 hours. Usual characteristics of the headache are unilateral location, pulsing or throbbing quality, moderate to severe intensity, aggravation by physical activity such as bending or climbing stairs, and it is associated with gastrointestinal upset ranging from anorexia to nausea or even vomiting, and sensitivity to light and to sound and often to smells. About 20% of migraine patients have migraine with aura, although these patients do not usually have auras with every migraine attack. Aura is a series of sensory disturbances that usually happen within minutes to an hour before a migraine headache attack. These disturbances range from seeing sparks, bright dots, and zigzags to tingling on one side of the body or even an inability to speak clearly. Auras commonly last 20 minutes, and the specific symptoms of an aura often change and evolve during that time. Characteristics of the aura include a mix of positive and negative features, such as a partial loss of vision with shimmering lights on the leading edge, called a scintillating scotoma. Over the 20 minutes of the typical aura, this shimmering blind spot will grow and move across the visual field. During sensory auras, the numbness and tingling will usually progress from the fingers, up the arm, and into the face.
Thank you, Dr. Solomon. Now, what's the relationship between migraine and cardiovascular disease?
Let's first dive in by looking at some studies. While these studies are observational and do not prove cause and effect, the results have been duplicated in other observational studies. The Women's Health Study evaluated 40,000 female healthcare professionals and followed them for 10 years. At the beginning of the study, the women were over the age of 45 and without cardiovascular disease. This population had an 18.4% prevalence of migraine, with 40% reporting an aura in the past year. A key finding from the study noted that the risk of cardiovascular disease in women with migraine without aura did not differ from women without migraine. However, the group with migraine with aura had a significantly increased risk of cardiovascular disease. For major cardiovascular disease, the hazard ratio was 2.15. For ischemic stroke, the hazard ratio was 1.91, and for myocardial infarction, the hazard ratio was 2.08. The hazard ratio for ischemic cardiovascular death was 2.33. Finally, there was a twofold increase in risk of composite outcome of cardiovascular disease or stroke. The other major study of migraine and cardiovascular disease was the Nurses' Health Study 2. In this study, investigators followed over 115,000 female nurses for over 20 years. At the beginning of this study, the women were aged 25 to 42 and were without cardiovascular disease. Information on aura was not available. They found that women with migraine had an approximately 50% increased risk of cardiovascular disease. For major cardiovascular disease, the hazard ratio was 1.84. For stroke, the hazard ratio was 1.89. And for myocardial infarction, the hazard ratio was 1.79. The hazard ratio for ischemic cardiovascular death was 1.66.
Wow, those are humbling results. What about for men? Is something similar found?
Excellent question. Let's review the data. The Physicians' Health Study followed over 20,000 male physicians for over 15 years. At the beginning of the study, the average age was 56 years, and the men were without cardiovascular disease. The prevalence of migraine was 7.2%, and information on aura was not available. Men with migraine had a 24% increased risk for cardiovascular events and a 42% increased risk of myocardial infarction.
Those are also eye-opening results. You mentioned ischemic stroke as a concern. How much of an increased risk is there for patients with migraines?
Ischemic stroke is another major concern for migraine patients. A meta-analysis including over 600,000 participants found that a history of migraine is associated with a twofold increased risk of ischemic stroke. Other studies found that in women with migraine, compared to those without migraine, the relative risk of stroke was threefold elevated. Compared with a baseline risk of 6 per 100,000 per year for women without migraine, the absolute risk for women with migraine was 19 per 100,000 per year. This elevated risk occurred in female migraine sufferers aged less than 45 years. The risk of stroke associated with migraine declined with increasing age. There was no association between migraine and stroke in the elderly. The risk factors for stroke in migraine patients include migraine with aura, high frequency of attacks, defined as more than 12 per year, hormonal contraceptive use, smoking, and with pregnancy and preeclampsia. So to put this into perspective, when I see a young woman with migraine with aura, I can tell her that she has a 2 to 3 times increased risk of stroke, but that the risk of stroke in young women is so low that increasing the risk threefold is still very small. However, I then explain that smoking increases the risk tenfold, and using oral contraceptives increases the risk 12-fold. The combination of migraine with aura, smoking, and oral contraceptive use increases the risk of stroke 40-fold.
Wow, that is staggering. I think it's worth stating a second time. The combination of aura, smoking, and oral contraceptive use increases the risk of stroke 40-fold.
It certainly gives you pause. Now that we've identified that migraine, particularly migraine with aura, is a risk factor for cardiovascular disease and ischemic stroke, we need to look at risk factor profiles. People with migraine tend to fall into lower socioeconomic groups, in part due to migraine impacting their ability to work. This may lead to an increase in traditional cardiovascular risk factors. Patients with migraine with aura were more likely than controls to have risk factors of elevated cholesterol, hypertension, oral contraceptive use, diabetes, and smoking. Migraine is associated with several non-atherosclerotic vascular disorders, including vasospastic angina, livedo reticularis, and Raynaud's syndrome. There is evidence from the Women's Health Study and also the Italian Project on Stroke in Young Adults to suggest that the risk of migraine-related stroke is inversely related to having a favorable cardiovascular risk profile. This fits with the hypothesis that migraine-related stroke is not atherosclerotic. This would help to explain why the risk of stroke associated with migraine declined with increasing age, and there was no association between migraine and stroke in the elderly.
Thank you, Dr. Solomon. So we've talked about migraine. Are there other headache disorders where we need to consider cardiovascular risks?
Yes, although much less common than migraine, cluster headache is important from a cardiovascular perspective. Cluster headache is a disorder of excruciating, strictly unilateral headaches centered around the eye that last 15 minutes to 3 hours. These occur 1 to 8 times a day. The pain is associated with unilateral conjunctival injection, tearing, nasal congestion, and rhinorrhea. These attacks often awaken the patient from sleep. Cluster cycles usually last from 1 to 3 months and then go into remission for months to years. Cluster headaches occur in about 1 in 1,000 men, compared with 6 in 100 men having migraine. It is between 3 and 10 times more common in men than women, and more than 80 to 90% of cluster sufferers are current or former smokers. Also, while migraine starts in children and teens, cluster usually starts in the mid to late 20s and is a disorder of middle-aged men. Because cluster most commonly occurs in middle-aged male smokers, it is important to consider the risks of treatment with vasoconstrictor drugs like triptans and ergots.
With this knowledge, I would like to talk about the risks of different treatments in patients with migraine as it relates to cardiovascular disease.
First, let's talk about the acute treatment of migraine. For many years, until the triptans became available in the 1990s, ergot derivatives were a mainstay of migraine treatment. These drugs were active across many vascular receptors and were vasoconstrictors. They were contraindicated in patients with cardiovascular or peripheral vascular disease. The triptans revolutionized the acute treatment of migraine, worked only on serotonin receptors in brain and blood vessels, but were also contraindicated in patients with cardiovascular or cerebrovascular disease. Research has shown that the vascular risk in patients older than 50 who use triptans is very low. Nonsteroidal anti-inflammatory drugs were considered a non-vasoconstrictor alternative to triptans and ergots. However, they have been shown to increase the risk of acute cardiovascular events, beginning as early as the initial dose. The NSAIDs with the greatest likelihood of cardiovascular events are diclofenac, indomethacin, and meloxicam. The NSAIDs least likely to trigger cardiovascular events are naproxen and ibuprofen.
What options do we have for migraine patients with established cardiovascular or cerebrovascular disease or significant risk factors?
As a first step, we should always try to manage cardiovascular risk factors in patients with migraine with aura. We need to emphasize smoking cessation, hypertension control, and management of diabetes. For the treatment of migraine attacks in patients with cardiovascular disease or significant risk factors, in the past few years, 2 new classes of acute migraine treatments that lack vasoconstrictor effects have been developed. These are the DTANs with the drugs lasmiditan and the GPANTs with the drugs rimegepant, ubrogepant, and zavegepant. Although these drugs appear to be somewhat less effective than the triptans and are much more expensive, they do not carry the contraindications for use in patients with cardiovascular or cerebrovascular disease.
Thank you. That is helpful. What about for prevention? It seems some of the medications we use for prophylaxis were originally cardiovascular medications.
Absolutely correct. For the prophylactic treatment of migraine, cardiovascular medications have long been an option. This is particularly valuable for patients with concomitant hypertension, arrhythmias, or heart failure. Beta blockers like propranolol, timolol, metoprolol, atenolol, and nadolol, calcium channel blockers like verapamil, angiotensin-converting enzyme inhibitors and angiotensin receptor blockers like lisinopril and candesartan have been shown to be effective migraine preventive drugs. Of these drugs, only propranolol and timolol are FDA approved for migraine prophylaxis. Other drugs that are used for migraine prevention include antidepressants, such as tricyclics and SNRIs, anti-epileptic drugs like topiramate and valproate, and the gepants, atogepant and rimegepant. Monoclonal antibody calcitonin gene-related peptide, or CGRP, antagonists, erenumab, galcanezumab, fremanezumab, and eptinezumab, are also used for migraine prevention. For patients on multiple medications where there is concern about potential drug-drug interactions, the monoclonal antibody CGRP antagonist drugs provide a valuable option. These drugs work on either the CGRP receptor, like erenumab, or the CGRP ligand, like galcanezumab, fremanezumab, and eptinezumab. These agents are largely free of drug interactions and are well tolerated. Erenumab has been associated with hypertension, however. Hypertension is seen most commonly after the first dose of erenumab. Elevated blood pressure can occur at any time during treatment, but is reported most frequently within 7 days of erenumab administration.
Thank you. What about prophylaxis of cluster headache?
For episodic cluster headache prevention, verapamil, with an initial target dose of 240 milligrams daily, generally is considered the drug of choice. Lithium, up to 900 milligrams daily, is an alternative. Because these drugs take at least 1 week to begin reducing cluster attacks, bridging with short-term steroid therapy, either 2 to 3 weeks of oral prednisone or greater occipital nerve injection with steroid, should be considered. If these drugs are ineffective or contraindicated, galcanezumab should be considered. Like migraine, cluster headache activity is associated with alterations in CGRP levels. Galcanezumab 300 milligrams monthly was studied for the prevention of episodic cluster headache. The mean reduction in the weekly frequency of cluster headache attacks was 8.7 in the galcanezumab group compared to 5.2 in the placebo group. Galcanezumab has not been shown to be effective for patients with chronic cluster headache, however.
We've talked a lot about treatment so far. In the last few minutes, can we go through some clinical scenarios, reviewing how you might prescribe these medications?
Sure. For a young woman with no comorbid conditions, one might prescribe a low dose of a once-daily beta blocker or verapamil. If a patient had migraine and concomitant insomnia, the clinician might choose a sedating tricyclic antidepressant if weight gain was not a concern. I would avoid ACEs and ARBs, as well as anti-epileptic drugs topiramate and valproate, due to their potential teratogenic effects. For a man with migraine and comorbid hypertension, one might prescribe a low dose of once-daily beta blocker or verapamil or candesartan, which is a drug we would have avoided in women of childbearing years. Patients who fail a trial of therapy should try a medication from a different drug class. It is reasonable to try different types of antihypertensives, beta blockers, calcium channel blockers, or angiotensin receptor blockers, antidepressants, tricyclics, SNRIs, or anti-epileptic drugs topiramate or valproate. Patients failing multiple preventive therapies may be candidates for more expensive treatments, such as CGRP antagonists, or for chronic migraine, onabotulinum toxin A. The CGRP antagonists may be effective when other preventive medications have failed.
Thank you so much, Dr. Solomon. This has been an outstanding discussion. What are some key points for our listeners?
Today, we discussed that migraine are very common and often debilitating. Migraine, especially migraine with aura, has been associated with cardiovascular disease. Women with migraine had an approximately 50% increased risk of cardiovascular disease, while women with migraine with aura had a twofold increase in cardiovascular disease. Men with migraine had a 24% increased risk for cardiovascular events and a 42% increased risk of myocardial infarction. A history of migraine is associated with a 2 to 3-fold increased risk of ischemic stroke. The risk of stroke associated with migraine declined with increasing age, and there was no association between migraine and stroke in the elderly. We briefly discussed cluster headache and noted that cluster most commonly occurs in middle-aged male smokers. It is important to consider the risk of treatment with vasoconstrictor drugs like triptans and ergots. Lastly, we discussed the risk of using ergots, NSAIDs, and possibly triptans in patients with cardiovascular or cerebrovascular disease. We spoke about acute migraine treatments that lack vasoconstrictor effects, the gepants, and the detans.
Thank you again for your time, Dr. Solomon.
Thank you so much for having me. I've enjoyed the discussion.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.